Welcome back, Health Impact audience. We are continuing our conversation around the well-being of the workforce in the wake of COVID-19 and all the other stresses that we've already heard about. You just had a great presentation from Wendy. We ran through a lot of overview and how this is a big problem. We've got coming up now, Jonathan from Mount Sinai. He's been focused on this particular problem of burnout, well-being, however you would like to call it, for a while now. And so he's going to go through a case study about what they've learned about this at Mount Sinai. And then following up, we're going to have a couple more case studies from other organizations as well. So Jonathan is a professor of medicine, medical education and geriatrics and palliative medicine at Mount Sinai Medical Center, and the chief wellness officer at the Icahn School of Medicine. And often we hear of wellness in terms of patients, but a lot of the work that Jonathan is doing is, of course, focused on physicians' wellness and clinicians' wellness and workforce wellness as well. So he's going to talk a little bit about that. So Dr. Rip is also the co-founder and co-director of CHARM. That's the Collaborative for Healthcare and Renewal in Medicine, which is an international group of medical educators, academic medical center leaders, experts in burnout research and interventions, and really trying to promote learning and trainee wellness. So this is, again, focusing on the workforce. And as you ask questions during the presentation here, try to focus those questions around less around patient wellness and more about the physician and clinician wellness. And Dr. Rip's primary research interest is in physician burnout and well-being, and he's received grant support and has published and lectured widely. So be able to look up all of his material afterwards. So his multi-center studies have served to better elucidate the causes and consequences of physician burnout, and exploring interventions, which is really the focus of this talk, is what interventions work, don't work, and which ones are promoting trainee well-being going forward. With that, Jonathan, take it away. Teach us about the well-being in the wake of COVID-19.
Terrific. Thank you so much for that introduction. I'm delighted to be with you all. Maybe we could go to the first slide. So before I get to sharing with you our experience at Mount Sinai, particularly as it relates to addressing clinician well-being in the setting of the COVID crisis, I provide this slide for you by way of background, just to share that we had an existing infrastructure. It's an important point I want to make because I think it really influenced our ability to act and take action in the midst of the crisis. And we were very fortunate to have an Office of Wellbeing and Resilience that I run. We've worked to create this model of healthcare well-being over the years as the way in which we at Mount Sinai sort of bucket the categories in which we try to have interventions and action. It'll look similar to other models you've seen, whether it's the Stanford model or the National Academy of Medicine model. We've sort of developed this on our own for internal purposes largely, but it addresses the ways in which we take action and took action in the midst of the COVID surge. Next slide, please. This will look familiar. It no doubt reflects what our previous presenter shared with you as it relates to the seriousness of this issue. Again, just by way of background, that there is obviously a case to be made to address the well-being of clinicians and burnout, both from a personal standpoint and the professional consequences. Certainly enough here that you see to take action and led us at Mount Sinai to take action leading up to the crisis that we experienced recently. Next slide. So what I want to share with you is the three main categories or the greatest stressors that we experienced in the midst of the pandemic surge, the surge of COVID patients that we saw. In fact, Mount Sinai saw the first patient in New York towards the end of February, which obviously preceded a huge number of patients. And so the curve, the pandemic curve, really also had stressors associated with the phase. In the beginning, in early March, as we knew that there was going to be a large number of patients coming in, certainly the greatest stressors were around the societal disruption that we've all experienced now, where just meeting our basic needs was a big challenge. And most of our workforce began to ask questions like, How will I be kept safe? Will I have enough personal protective equipment? Will I be putting my loved ones at risk when I come home? Who's going to care for my children now that schools are closed? Will it be safe for me to take public transportation? How do I get my next meal? All of those things became front and forward at the beginning of this pandemic. And then we hit a phase in which uncertainty sort of took over as the major source of stress. And for this, in my role, I've really been humbled by the impact that uncertainty has on creating anxiety. And so all those questions around how long the surge is going to last, how long will this increased workload continue? Will I be able to do my job if I'm redeployed outside of my usual setting and have to work in another setting on a COVID unit, perhaps? Will I be prepared? Am I doing enough? There's sort of that bit of guilt experienced by people who were in clinics that were now entirely shut down, and they were feeling like that they were home and perhaps not doing enough. Will they be supported by the health system? Will their needs be met? And what if they have to make really difficult decisions about limited resources, if ventilators run out and that sort of thing? A huge amount of uncertainty that we dealt with. Of course, we still deal with this. We still have issues around the meeting basic needs. The issues of childcare have come up again. But then as the numbers of patients started to decline, and now we have a very low prevalence, thankfully, in New York City, while the rest of the country in other hotspots are really experiencing a surge, we at least had some time where we were processing what it was we went through, which was really a communal trauma in which no one was spared. We experienced grief and loss. And for some, there was concern about post-traumatic stress. There still is. And certainly that was around the time of all the ongoing societal upheaval and attention to racial injustice. So just a huge amount of stress experienced. I do put in there that for some, it's not all negative. Some experience post-traumatic growth. This is a known phenomena where by virtue of taking part in the experience of contributing to the care of patients during COVID, some will look at this as a very meaningful time, which I think is probably reflected in some of what you've heard previously about deriving meaning from work. I think if we look at the next slide, you'll see the way in which we address that. So I'll just jump to strategy 2 there, communication. So we felt the best way to address uncertainty, if it's uncertainty that's driving stress, then providing information is the means to address that. And, admittedly, we have 40,000 employees, so ultimately they're the ones that will be able to say whether or not they feel like their institution had their back and they felt the information we gave was trustworthy. But a huge effort was undertaken to provide honest, authentic, transparent communication. Having been at the institution for 20 years, I can honestly say the messaging that came out during the crisis was some of the most heartfelt and authentic messaging that I've seen, and I'm not the only one who reflected on that. So I think we did do our part to address the uncertainty in that way. I do hope that the institution reflected that. There were other means we communicated, weekly messages that went out, town halls, other strategies we put into place to deal with some of those other stressors were meeting the basic daily needs, whether it's clarity and provision of personal protective equipment, if the fear was around personal safety, childcare resources, transportation, food, and so forth. And now moving into the phase where we have fewer patients and sort of the post-acute period, it's where we remain very concerned about psychosocial mental health issues and have expanded existing resources and developed new resources, many of which were active during the crisis, some of which are now sunset. But those include things like support groups, new ways of doing them by Zoom, virtual groups, crisis lines, making psychiatry available through telepsychiatry, and a lot of frontline relief. Putting sources of relief right in the workplace was another thing that we did. We captured a lot of this through a publication that we put out in April in JAMA, which I leave for you here to review. But essentially, when you ask people what their needs are and what they want in the midst of crisis, it boils down to sort of 5 areas, which are captured on the left of this diagram. Hear me, protect me, prepare me, support me, and care for me. That's what people really want and when I refer to people, I mean, of course, the healthcare workforce in the midst of this crisis. They need to be heard, they need to feel safe and prepared, and they need the basic human need that you're supported and cared for. Next slide, please. Again, we captured this in a paper, Attending to the Emotional Well-Being of the Healthcare Workforce, which speaks to what I'll get to in just a moment, sort of the main thrust of our interventions. But they focused on a figure from another publication, that sort of pyramid, the modified hierarchy of needs. And you see there that, ultimately, as human beings, we need to have our basic needs and our safety addressed before we can look at these other issues around respect, appreciation, healing patients, and contributions. Not to say that those all can't be done concurrently, but when it's your basic needs that often need to be met first, and then all these other things. Then there's space for these other areas. We attempted to address all of these. Next slide. And one of the things we did was we rather quickly put up a website together. Our entire digital health team pivoted in the midst of crisis and directed all of their time and attention and energy to creating a new website, a staff COVID well-being, a COVID support website, of which there was a well-being component. You see here what would be the landing page with links that can be seen. Next slide. Here, these links represent sort of the basic thrusts of our approach. So we created tabs for basic needs and self-care, and after listening to the different constituent groups and understanding what their needs were, hearing them, we addressed what provision of basic needs and self-care, as you see on the left side of the screen. And then, of course, what I spoke to earlier about the tremendous importance ongoing for creating mental health and psychosocial support. We tried to make this user-friendly. So whether it's crisis support, one-on-one, group-based, spiritual, you can see it all here. We also put into place these frontline relief snack stations and centers. What we found, these were very well received and asked about. And these are durable throughout, so they remain. Not the snack stations, but what we now call recharge rooms. These are immersive spaces that some very talented people put in place and ramped up quickly at all of our hospital sites, where there's music, scent, meditative, visual elements. If it looks like that's a picture of the rainforest, that's what it feels like where you are when you enter these rooms. So if you have a 5 or 10 minute break, it does an enormous amount. Again, that's sort of basic need, just to take a rest when you need it. Next slide. So hopefully that gives you a sense of what it was we went through. I know it was pretty quick, and also gives you a sense of how we really pivoted from a lot of what had been our priorities before COVID to some new priorities within the crisis. This slide captures sort of the major areas that prior to COVID were often what I spoke of when making the case, whether it's the moral imperative, whether it's the business case, the regulatory case, or the tragedy of suicide. Those tended to be the main sort of arguments that could and have been used to support institutional, organizational approaches to well-being. I now am remembering you asked a question about that I didn't fully answer about what if you're not at a large institution. There's lots of resources out there. You can certainly, our website is open, so you can get a sense of what it is that we do at an institution. And there's lots of resources that are available through other organizations, accrediting bodies like ACGME as it relates to residents, the National Academy of Medicine, the American College of Physicians, and more have a huge number of resources that are available. And I'm happy to remain a resource to you all if you need some navigation to that. I believe it. Yeah, this is a sort of an adaptation of an article that captures the stages of readiness for change to commit to efforts in clinician well-being, in workplace well-being. And, I think, and each sort of column there captures what stage, whether it's a large institution or a small practice. It's not necessarily about going from novice to expert. It's about moving along the spectrum to a greater commitment and kind of recognizing the value in doing so. And I think, if anything, this crisis has increased our attention and understanding, and maybe help shift everyone a little bit further along this spectrum. Next slide. So I think this is near the end. I'll just say that certainly in our experience, we needed to pivot in light of the pandemic. It was fortunate that we had an infrastructure to address well-being in place. I recognize that every institution and practice may be at a different stage, but like I said earlier, it's not about getting to having the type of that everywhere should commit at the extent that we did. It's more about committing more and understanding the need to at whatever stage you're at. Certainly the drivers of well-being may lead to shifting priorities in the midst of a crisis or societal change. And almost certainly trauma and moral distress will lead to some significant long-term consequences. We, in fact, have unpublished data from a survey sent to almost a little more than 6,000 of our workforce, showing a considerable burden of these mental health outcomes, whether it's PTSD, depression, and anxiety. So I guess where to from here? We like the mantra that everyone can benefit from support. Everyone in the healthcare workforce has been through this sort of shared traumatic experience, so we can all benefit from support. Some of us will be more impacted and may benefit from treatment which is highly effective for those outcomes that we found in our health system. And so, in the end, there's reason to believe that we'll all come out, not all necessarily, but the great majority of us will do just fine in time. And for those that have long-term consequences, it's important that we encourage and destigmatize help-seeking behavior. One of the ways we're doing that is captured on on my last slide, is through the development. If we can go to the next and last slide. We recently started a Center for Stress Resilience and Personal Growth, which the intent really is to provide resources to our workforce, resilience training, mental health screening, coaching, and referrals for treatment if needed. All part of a collaborative effort across our health system to normalize the need for support and treatment when needed. And with that, I think I will close and thank you for the time.
Yeah, that's fantastic advice. So we really appreciate you taking the time here, Jonathan, to talk to us during the Health Impact session here. And if anybody in the audience needs help, Jonathan is an email or a phone call away. They've got resources that he can point you to, as well as stuff that they've done. So do take him up on that offer if you can. And with that, we'll turn it over so we can start the next session.
Thank you.